So what are the risk factors of ovarian cancer? Now, risk factors are certainly low parity or infertility, a history of breast cancer. A history of breast cancer increases the risk of ovarian cancer, secondary primary ovarian cancer, by about 60%. Another risk factor that is well known and we can actually deal with is BRCA. And we're going to speak about BRCA, but BRCA stands for breast cancer gene. It's a tumor suppressor gene. That means that we all have a BRCA gene in our body, and in normal function it controls the DNA replication. And it basically weeds out bad or mutant DNA. So for example, if a replication error occurs in a normal human, BRCA would eliminate the mutant DNA, cut it out and put the healthy bits together. Now if BRCA is mutated, and this is what we mean in this context, then these cancers occur. Normally genes are present in our body in two alleles. And basically, you can imagine that the two alleles are like guardians. And if one guardian sleeps and the second guardian also sleeps and they are completely falling asleep, you can imagine that all kind of mutant DNA gets replicated and translated into proteins. And this is when we see then the effects. So what are the effects? The effects are cancer, cancer of the ovary, the breast, the pancreas. What are the hallmarks? The hallmarks are young age at diagnosis. We see breast and ovarian cancer patients diagnosed in their 30s. Clustering of cancers within families, and we're talking about ovarian, breast and pancreas cancer. But we also see multiple cancers within the same person. So what I'm saying to you is, if you diagnose any of the hallmarks, please be aware of the possibility of BRCA mutation and refer to clinical genetics. Now, there are risk factors, but there are also preventative factors. Now, those factors are the oral contraceptive pill reduces ovarian cancer risk by 50%. And that is true for spontaneous ovarian cancer and for hereditary ovarian cancer. Tubal ligation and salpingectomy reduces the risk of ovarian cancer also by about 50%. Bilateral salpingo-oophorectomy reduces the risk of ovarian cancer by 95%. You can see that it does not reduce the risk by 100%, so there is a 5%, a very small chance that still some peritoneal cancer can develop, because ovarian cancer normally does not develop from the inside of the ovary, but from the outer shell, which is covered by peritoneum. Now, there was a little bit of a hype last year in 2012 about prophylactic salpingectomy and whether we should actually remove the fallopian tubes to reduce the ovarian cancer risk. And I thought I'd elaborate on this a little bit. The whole discussion came about because there were incidental findings of occult ovarian cancers within the fallopian tube, and to be specific, in the distal fimbrial part of the fallopian tube rather than in the ovary itself. So basically, when we do prophylactic risk-reducing surgery, we remove specimen, send it off for pathology, and they found incidental findings of fallopian tube cancers in a number of cases. But there has been no study ever that prophylactic salpingectomy is actually beneficial. So we need to say, unfortunately, it's still unproven and hypothetical. But if you ask me as a clinician, do I recommend salpingectomy for certain groups of patients? I'm saying to you, well, if we have very young patients who are at very high risk of developing ovarian cancer at young ages, one of the things that we could do is we could remove the fallopian tubes and manage that risk that way without making them menopausal straight away. Of course, these women would require IVF if they then decided to have children. Now, if we then find a pelvic mass, it would be nice to determine what is the actual risk of malignancy. And there is a risk of malignancy index that has been published in 1990, so some 23 years ago, by Ian Jacobs. And basically, we can very easily apply that. You and I, we can apply that very easily in our daily setting. We basically give points for menopausal status. We give 1 point for premenopausal, 3 points for postmenopausal. We give points for ultrasound features, like 1 feature, 1 point, more than 1 feature, 3 points, and we give points for the serum CA125. And for example, if we had a postmenopausal woman, we get 3 points. We get some ultrasound features. Let's say we find multiloculated solid mass and it's bilateral. Let's say we have 3 points here, so 3 by 3 is 9. And then we multiply that with the absolute CA125 level. And let's say the CA125 is 100, then our risk of malignancy index is 900. We normally use a cutoff of 200. Everything above 200 should be referred to a gynecological oncologist for further management. Everything less than 200 can be treated with the general gynecologist. Just a few examples of bowel surgery. So this is an en bloc resection where we basically transect the large bowel at the level of the sigmoid colon, at the rectus sigmoid, and we also transect the rectum and everything that is within the pelvis, including the rectum, the uterus, the ovaries, will get removed in one piece. And in gynae-oncology, we always try to basically hook up the bowel to do an end-to-end anastomosis, and that is shown in the lower picture. Sometimes we may need a loop ileostomy to cover the rectal anastomosis, because keep in mind, these patients had chemotherapy before, they are going to have chemotherapy afterwards, and the risk of an anastomotic leak is certainly much higher than in patients, let's say, where you do a rectal resection for a rectal cancer. We resect the ureter, and on this picture you can see a ureteric stent on the left-hand side, and the ureter there, and the ureter is just plugged into the bladder on this image. This happens to be a patient who also had a rectal resection with an end-to-end anastomosis. We do, sometimes if we have to do, we do a liver resection. I've done with one of my colleagues one last week, because the liver was the only spot where there was still tumor there, and we actually could render the patient disease-free. Resection of the diaphragm, you can see that the diaphragm is infiltrated with tumor. The diaphragm is a barrier between the abdomen and the chest, and we find cancer there quite frequently. So why do we do all this? Why do we do these massive operations? Why is optimal surgery so important? Well, because chemotherapy kills tumor cells by 1 log per each treatment cycle. And basically, if we start chemotherapy at, let's say, 10 to the 12th, we get down to 10 to the 6th after 6 cycles of chemotherapy. But what would happen if we start with surgery? We start at 10 to the 6th and we give 6 cycles of chemotherapy. We end up with no tumor in the end, and that's what we want to achieve. And 10 to the 6th is actually roughly the level where patients are macroscopic tumor-free. So I'm saying if we render a patient macroscopically disease-free, we're actually at the 10 to the 6th level. And here are some figures that actually back up what I'm saying. What the curve says is that if I increase the maximum cytoreductive surgery percentage, the survival will go upwards and will improve. And I can actually double the survival by just improving my surgery. And data have shown that in patients who had exactly the same chemotherapy but different surgery, survival improved by more than double. Now there are new drugs on the horizon, and one of the drugs is bevacizumab or Avastin. Avastin is approved in Australia. It's TGA approved. It can be given, but at the recording of this talk, it is not reimbursed as yet. Avastin is a medication that blocks angiogenesis, that blocks the formation of new blood vessels, and it's supposed to starve the tumor. There are a few early studies, a few phase 2 studies, and I've given you some results here, and amongst a lot of drugs, bevacizumab or Avastin has shown the most promising results. There are a few phase 3 clinical trials, and they have shown a benefit in terms of disease-free survival, but not in overall survival. But what I'm curious in seeing is if we combine those phase 3 clinical trials and bring them together and create a much larger data set, I'm curious to see if there is a survival benefit there, and that would give Avastin PBS approval in Australia and reimbursement, and then patients would be eligible for Avastin. Point number 2, services that patients receive. Referral to a gynecological oncologist or to a tertiary center. These are some data that we published in 2007. We have basically shown that patients who were treated in large tertiary institutions have a 24-month median survival, and the median survival drops to below half if the same patients were treated in small hospitals. What I'm saying to you is the surgeon or the institution, the treating institution, is actually a prognostic factor. This is a Kaplan-Meier curve. It gives me information on the survival probability of patients. And the interrupted top curve shows the survival chances of patients who had surgery with someone who frequently performed radical procedures for ovarian cancer. And the below curve, and their survival is about 50% at 5 or 6 years. Below then, the continuous line is survival probability of patients who had surgery with a surgeon who hardly ever performed radical procedures for ovarian cancer. And you can see that their survival is almost zero at 5 or 6 years. So yes, the institution, the hospital, the surgeon is a prognostic factor, and I do recommend that if you see patients with ovarian cancer, you refer directly to a gynecological oncologist rather than to a general gynecologist. A word to screening, because this is something that you certainly will be exposed to. Patients will come and see you, women will come and see you and request screening for ovarian cancer. Now, we said before that most epithelial ovarian cancers are diagnosed at advanced stage disease, stage 3 or 4, because of the lack of symptoms. Screening is the idea that asymptomatic women shift from stage 3 and 4 with poor prognosis to stage 1, where the disease is confined to the ovaries and the prognosis is much better. And that's certainly a concept, but unfortunately that concept has never ever been verified. I realize that we all want this concept, we all want this to happen, but unfortunately it has not been confirmed as yet. This is a trial, the largest trial to date, that's been published 2 years ago. It's an American trial, enrolled 80,000 women, half of them were screened. The screening was ultrasound NCA125. Patients were followed for up to 13 years. The endpoints were ovarian cancer incidence and mortality. Now, one word of caution, 10% of the screened women had a false positive result that led to an operation. And of those women, 15% developed a serious complication following from surgery. Now, what did the trial show? On this slide, you can see the cumulative incidence of ovarian cancer. And as you can expect, in the screened group, in the intervention group, which is the top line, we find more ovarian cancers than in the usual care group. But when we go then to the next slide, we can see that there is absolutely no survival difference. These are cumulative death and the probability of dying, and the screened and the usual care group are exactly the same. You could even say that the death rate is slightly higher in patients who have been screened for ovarian cancer than those who have not been screened. So I think we can summarize that routine screening of asymptomatic women for ovarian cancer is not recommended by any professional society worldwide in 2013. We're expecting data from the UK in 2014, and they could change the game, but we need to wait for those data. But so far, no trial has shown a survival advantage with screening. Thank you very much for your attention. I'm very happy to be contacted if need be. You can see my details on the slide. I thank you very much and hope you have a good day. Thank you.